Morning, everyone. My name is David Banksburg, Chair of the Oregon Health Policy Board. Just waiting for a few more members to join us and we'll get the meeting underway. Morning, everyone. My name is David Banksburg, Chair of the Oregon Health Policy Board. We will start. We're waiting for a couple more members to join, and then we'll start the meeting. Morning, everyone. I'm David Banksburg, Chair at Oregon Health Policy Board. We'll start our October Oregon Health Policy Board meeting. Good morning. Great to have you join us. Just as a reminder, the Zoom feature in today's chat, or the chat feature in today's Zoom meeting is only allows meeting attendees to message the host and the co-host, not other meeting participants. If you have questions or thoughts or want to communicate with the OHA staff via Zoom, please send an email to healthpolicyboard at dhsoha.state.or.us. That's healthpolicyboard, one word, .info at dhsoha.state.or.us. And we'll move forward with a roll call. Oscar?
Here.
Kirsten Isaacson?
Here.
Bill Kramer?
Here.
Brenda Johnson? Brenda's not with us today. John Santa?
Here.
And I think Ebony Clark is out today. Will join us, and nor will Jessica Gomez. So Tara, do we have a quorum? We have several votes today.
Yeah, we do. I just wanted to share. So Brenda was logging in. I think she was having some issues, but we have Oscar present. We have David Bangsberg. We have Kristen Isaacson, Bill Kramer, and John Santa. And Brenda will be here in just a moment. So we will have 6 of our 8 members.
Great, very good. Thank you. Just a couple announcements. In your packet today, you will find a Q3 committee digest included as attachment 1.2. We've updated the digest to include additional committee information, including the committee chairs, membership, and vacancy numbers. We also highlight that on the committees that we're currently soliciting new members, the Health Equity Committee and New Cost Growth Target Advisory Committee is accepting new members, applications for new members. To learn more about the committees and the solicitation, please see the committee update in the digest. The links to the committee is also included in today's agenda. If you have any questions, please contact Tara Chetok, the Oregon Health Policy Board Manager, or the lead committee staff. Also of note is we've included the Oregon Health Policy Board guiding principles for decision making, which is included today because we have several votes. For our meeting today, We have a full packed agenda. First, we'll hear from Director Pat Allen regarding the director's update. We'll hear from the Health Insurance Marketplace Advisory Committee. Will join us to provide an introduction to the newest committee and their updated bylaws for Oregon Health Policy Board vote and approval. We'll hear the committee membership project on its final findings and recommendations as the next step for this work. The Healthcare Workforce Committee staff and chair will join us to present the final health equity framework report and proposed allocations for the Healthcare Provider Incentive Fund. This will also require a vote. Then we'll be joined by staff of the Healthcare Market Oversight Program to review and vote on the approval of the final draft framework for that committee. And then we'll conclude with a discussion of the cost growth target program. So a full agenda today. Let's start off on entertaining a motion for approving the minutes.
This is Kirsten. I'll move to approve the minutes.
Okay, thank you. As a second.
Second. This is Bill.
Thank you very much. All in favor? Aye.
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 Any opposed? And any abstain? Okay, very good. The minutes are passed. Pat, would welcome your update to get us off and running.
Great, thanks very much, Chair Bangsberg, members of the committee. I've got a few things to talk about today. Sadly, they still tend to be kind of pandemic dominated. I keep looking forward to getting to the place where that doesn't need to be the case. And every time we think we're turning that curve, we remember that the track is round. And so we're still sort of heavily pandemic, but let me go ahead and dive in. First, just in terms of where we are in terms of the pandemic and the Delta wave, cases have been steadily coming down for about a month now. The rate of decrease is steady but relatively slow. We just crossed over being at a level that was below the fall winter peak of last year. And this week looks like it's going to be a little flatter than last week, which was a little steeper than the week before. And that seems to be the way that things are going. Hospitalizations have come down significantly since their peak in this wave. ICU bed utilization has come down less slowly or more slowly than hospital beds overall, which is of concern. Deaths are also dropping. And of note, the death rate so far as we know it, and this is a lagging indicator for a couple of reasons, and sometimes it's a significant lag because we reconcile death records sometimes weeks or months after the fact. But so far it appears that the rate of death has decoupled from the rate of cases to a much more significant degree than the rate of hospitalization has. A little bit hard to pin down exactly why that would be, but we were at vastly higher rates of cases in this wave than we were last winter, and yet the death rate has been similar to what it was last winter, and so you didn't see the increase you would expect. Hospitalizations don't appear to have decoupled at all, and I think the most logical explanation for that is that this was really a geographic wave rather than a statewide population wave. It was really affecting the unvaccinated population rather than the vaccinated population. Had these cases been amongst vaccinated individuals, you would expect to see, and I think in more highly vaccinated counties, we did see much less hospitalization and much less death as a result of those cases. So we're continuing to monitor that. Hospital staffing continues to be a very critical issue. We continue to have a large number of traveling healthcare staff deployed throughout the state, as well as a large number of Guard members in non-medical positions to try to help get various hospitals through this level of surge. We expect that to continue for some time. We're going to continue the incident management team for hospital capacity that we stood up through probably at least the end of October to get through any needs that develop as a result of the vaccine requirement going into effect on October 18th. And I would also mention that the staffing, while the staffing shortage affects everybody everywhere doing anything, It's particularly noticeable in our world in healthcare, but I particularly want to call out that long-term care also is impacted by the same staffing shortage, and that has a direct impact on hospitals because it has an impact on the ability to get people discharged. We have set up discharge assistance teams that have been successful in getting about 500 people out of hospitals into various long-term care settings, which has been especially helpful, I would say, in Southern Oregon, where some of that stickiness has really had a serious impact on hospitals. And this is a capacity that that we're looking at trying to make more permanent. In many cases, these are people who are extremely complex with behavioral health and extreme physical health needs. And it's not just a matter of, there's some nursing home down the street that won't let them in. It's that they really need a very specific kind of a care setting, really tailored to their individual circumstances. And it takes a high degree of casework to do that. Now, I think one of the challenges is there's a sense that's accurate that we're already paying a bunch of people to do that. And so I think as we try to figure out how to maintain this capacity, we need to reconcile that. But this ability to really help get people out of hospital settings when we can, I think is a challenge that existed before the pandemic. The pandemic has highlighted it, but it's going to continue to remain and need to be dealt with. Vaccine requirements do go into effect on the 18th of October, and yesterday was basically the last day to get a final dose of a vaccine, either a one-shot Johnson & Johnson or a two-shot vaccine. We have provided for all of state employees, educational employees, and healthcare employees some frequently asked questions guidance that basically says everybody doesn't need to turn into a pumpkin on the 18th, but they can't be in patient and student facing work anymore at that point. And so that means if someone's got a shot on board and they're able to telecommute, you can have them telecommute until they get the second shot in the 2 weeks. If they don't have that capability, they can take, in the case of state workers, vacation or personal time off. They can do unpaid leave. So there's flexibility to not actually have to terminate people, but people still really do need to get vaccinated, and that time frame will go ahead and run out. The data points that have been emerging all over the country, including Oregon, are encouraging in that the actual numbers of people who decide to, in lieu of getting vaccinated, to terminate their employment is quite a bit lower than the threat of that, and so that's been good news. Now, even a 5% loss rate right now, big deal, and that's why we've kept our IMT stood up to monitor the circumstances and see where we're at. And like vaccinations generally, we think there will be geographic diversity around this, and so you could have some parts of the state where it's not a problem at all, and other parts where it's a big problem. We'll continue to monitor that. In terms of vaccinations, we're closing in on 80% of adult Oregonians vaccinated. I think as of yesterday per CDC, we were at about 78.5%. That's up from 70% at the beginning of July. Also of note, the vaccine disparity has continued to close slowly but steadily over the course of the vaccine effort. It's also worth noting, I didn't earlier, that the disparity amongst cases and amongst hospitalizations has also been closing over the last 6 months. There's a variety of reasons, good and bad, for that. Probably one of the drivers is the relatively rural nature of this most recent wave, and in cases being high in counties that tend to skew wider than other counties. But there is also a lot of good work being done by our partners locally and in community-based organizations that are helping achieve that. Boosters rolled out for a large subset of people who had received the Pfizer-BioNTech vaccine. It's not quite all adults, but you can shoehorn a lot of people into underlying conditions that increase risk, since that includes hypertension, diabetes, obesity, a large portion of the overall population. And that booster rollout has gone pretty smoothly. People's demand for boosters is not at all on the time scale. Sorry, I've got a dog wanting to be helpful by chewing the power cable on my the urgency for people to want to get boosters seems to be dialed back quite a bit. We're doing a lot of booster shots, but and appointments at pharmacies and those kinds of things tend to be fully scheduled, but we don't have lines around the block or those kinds of things. That could change as kids become eligible. The FDA's advisory committee on vaccines and related biologics will take up in mid-month the issue of boosters for Moderna and possibly boosters for Johnson & Johnson, which just submitted for approval. And then late in the month, they'll take up pediatric doses. So I don't expect anyone to be eligible for those pediatric doses before the end of October, but I think that demand will be higher. Those surveys would indicate there's only about 25% of parents who sort of answer in the category of, yeah, absolutely, the minute they're available, I want my kid to get it. Let's see what else. Monoclonal antibodies, just at the time that we were really kind of working to ramp up accessibility to that treatment, supplies began to dry up and the federal government switched to a centrally allocated system. So we get a state allocation that we then in turn direct shipment to those who are administering those. Supplies are beginning to even out a little bit and get closer to demand. One disturbing trend is that for whatever reason, it appears that kind of a branch of thinking out there among people is, I won't get the vaccine, but if I get sick, I'll get the monoclonal antibody. And the antibodies are not nearly as effective as actual vaccination. And so we're a little bit challenged in messaging around that. Last thing I'll touch on, just thinking about the pandemic overall as we're closing in on our second year of it. It's kind of acted like a solvent in a lot of systems. Every problem that we have out there is made a little bit to a lot worse by its exposure to the pandemic. And this last month or so has felt like the wheels are coming off a lot of different systems. And I think behavioral health is probably the one that's most on my mind, as we've seen huge challenges in all sorts of residential treatment settings, particularly, but everything about workforce, everything about acuity are all seeming to kind of peak right now. The legislature made some historic investments in the last session, but those almost all have some kind of a lead time on them that's not insubstantial. The first things that'll come online will be expansion of capacity at the state hospital beginning next month and into the first quarter of next year. But other investments are going to take months beyond that. And so what we're working right now to do is find ways to make short-term investments to try to just keep things together as best we can, keep a workforce intact as best we can. But it's a very challenging time right now that we're trying to work through. With that, Chair Bangsberg, I'll stop and see if anyone's got questions and kick my dog a couple more times so I don't lose power.
Thank you, Director
I
Allen.
won't really kick my dog, just for the record.
Open up for questions or comments from the board. Go ahead, John.
Yeah, Pat, thanks for those comments. As I listened, I think it would be really helpful if the committee members of OHPB committees could hear that or read that from you. At the last metrics and scoring meeting, there was quite a bit of both testimony and then concern expressed by committee members. They got the job done, but the concern was palpable, even remotely. And what you just said, I think, would help a lot. It would reassure them you all know that things are more tricky than ever, and you're doing a variety of things on all fronts to try and stabilize it. So, I might just ask for a bit of a special communication to OHPB committee members, summarizing, what you just said. Thank you.
Be happy to do that.
Thank you, John. Other comments or questions? Well, thank you, Director Allen. Hopefully this is the last surge we have on the way down. So I appreciate your and everybody at OHA's endurance in handling this this pandemic that keeps on going. Hopefully better times ahead. So thank you for your endurance, and thank you for everyone at OHA. We next will turn to public comment. The Oregon Health Policy Board welcomes public comment, and it's one of the most profound ways we demonstrate our commitment to listening and learning from you. Deep listening means that we will not provide immediate commentary on what you present to us today. However, we do discuss each public testimony in our working meeting, following working meeting with Mr. Arana and I and the OHA staff. And it's that deep listening that we hope to provide the attention, respect, and honor that you deserve. Each presenter is given 2 minutes, and it often doesn't feel like enough time. We also encourage written comment to supplement your oral comment. To help keep us on time, we have a new timer this month that you can watch and keep track of your time. Please know we appreciate your comment. Again, we review your comment carefully after each meeting. Today we have 4 people signed up for public comment, and we will start with Amy Alch. Please state your name and affiliation for the record. Amy Alch, are you here? We'll come back to Amy. Let's go to Adrian Peters.
Hi, thank you so much for having me. This is Adrian Peters, and I am the project manager for the How to Behavioral Health Grant with Northwest Oregon Works. And I just wanted to let you know that we have begun enrollment for our behavioral health program. We're serving Benton, Lincoln, Clatsop, Tillamook, and Columbia County. And we're particularly targeting BIPOC and bilingual individuals. And we're seeking to increase and up-level the behavioral health workforce. Starting my video as requested. Yeah, so far we have enrolled 2 individuals for our level 3, which is our clinical level. We have a max of 3 spots there. And one of the individuals is from the Siletz tribe in Lincoln County. And we had our first meeting with him. It was really promising. And we had another meeting with a BIPOC individual from Benton County. And we are just waiting on all of her enrollment materials. We have 2 individuals we're enrolling for level 2, which is our QMHA and our CADC level, enrolling for level 1. And that's for our community health workers, peer support specialists. And we're kind of looking at whether or not we could even work with some of our traditional health workers in a behavioral health setting. We still have 4 spots available for level 1, 2 more spots available for level 2, and then we're sort of negotiating that 3rd spot right now. We have a couple of candidates for level 3. So we're going to most likely be at capacity within the next month. I have several people that I'm responding to this week, and it's super exciting to get this off the ground. So I just wanted to share that.
Great.
Thank you.
Thank you very much for your comment and your good work. We'll next turn to Andrea.
Good morning, Chair Bangsberg and members of the Health Policy Board. I'm Andrea Sikora, here representing the Oregon Association of Hospitals and Health Systems. And thank you for allowing me time to comment today regarding the new healthcare market oversight program. We appreciate the work of the board to develop guiding principles and framework for reviews under this new program. Decisions to enter into material change transactions are not taken lightly by our member hospitals and health systems. And we agree that principles of equity, equitable access, quality, and costs should guide these decisions. Evaluating these factors typically requires some level of prediction and forecasting. And it's crucial that these predictions are supported with sound data to estimate the real-world foreseeable impact of the transaction. As we stated in our written comments, we asked the board to adopt a guiding principle to this effect. Additionally, we asked the board to state explicitly in its framework that the criteria listed therein shall be evaluated comparatively against the anticipated impact of not completing the transaction. This is an important piece of a holistic and comprehensive impact analysis. Finally, we acknowledge that the board has been presented with some data to suggest that healthcare mergers and acquisitions have a negative impact on cost and do not improve quality. And we wish to point out that there's not scientific consensus on that matter. We encourage the board to review the research cited in our written comments, which suggests that hospital acquisitions can and often do have a positive impact on both healthcare costs and quality. Thanks so much for the time.
David, you're on mute.
Oh, thank you. Thank you for your comment, and thank you for especially sharing that prior to our discussion on this topic later today. We'll next turn to CG, has signed up for a public comment. Is CG here, please? Is CG available? Okay. And then CG is not here. We'll go back and give one more try for Amy Ulch. Is Amy Ulch here? All right. Well, thank you very much for your public comment. We will move on to our next topic, with Health Insurance Marketplace Advisory Committee, the transition to OHA and Oregon Health Policy Board. Today we're joined by the Oregon Health Policy Board's new committee, which is Health Insurance Marketplace Oversight Committee. I had the pleasure to share some work about the board's priorities and the committees in the July meeting, and we're delighted to see the committee chairs and staff this month during our board meeting to share the committee's work and propose updated bylaws. We welcome Cheeky Flowers, the director of the Marketplace Committee, Dan Fields, and Shannon Saldivar, the chair and vice chair of the committee. And I want to remind the board members that today is this is a voting item where we are requested to provide a vote on the approval of the updated charter. So Dan, would you like to take it over?
Yeah, good morning, Dr. Bangsberg. I'll kick us off. Shannon and I are going to co-present this morning, so we'll sort of tag team here. Thank you so much for having us here. Our plan this morning is not necessarily to make you all experts in the marketplace or the Marketplace Advisory Committee, although we welcome that. Really, we just want to give you enough of an overview so that we can begin what will hopefully be a long and fruitful working relationship with the Health Policy Board. And as the Marketplace becomes integrated into OHA, and as the Marketplace Advisory Committee is integrated into the Oregon Health Policy Board, what we want to do is work together with you and set the stage for achieving some of the long-range goals that we all share for Oregon's healthcare system. So with that, we have a short slideshow that Shannon and I will go through, and then we'll do the bylaws that you mentioned, Dr. Bangsberg, at the end. That should be pretty straightforward. We'll let Chicky do that. But before we do that, we'll do a quick overview. So for those of you, it's good, by the way, to see a lot of familiar faces. For those of you who don't know me, I lead the external affairs and community health functions at Kaiser Permanente here in the Northwest. Shannon, go ahead and introduce yourself if you would.
Hi, thank you all for your time. My name is Shannon Saldivar. I'm a small business owner and insurance agent in the Columbia River Gorge.
Great. Shannon and I have been on since the very beginning, back I think in 2015 or 2016, when the Marketplace moved into the state agency, DCBS, and began its new iteration there. And so we've been on the advisory committee, I think, Shannon, for 6 years now, and seen the Marketplace through a lot of different major milestones. And we're not here to recount the 6-year history, or prior to that, certainly, but let you know that the Marketplace has traveled a long way. And we're really excited that today the Marketplace insures over 160,000 Oregonians. So it is a small but critical piece of the work of insuring Oregonians. And so a lot of times the Marketplace tends to get pigeonholed as sort of a slice offering, if you will, but it's critical in several respects. One, most importantly, it is the avenue for Oregonians to access federal matching funds and federal support. And without the marketplace, that just wouldn't happen. So as I said, it's a small but critical piece of providing the coverage umbrella for Oregonians. Let's dive into the slides if we could. I think, Annette, you're going to forward those for us. And I certainly won't read through the slides. I've already covered some of the cost sharing reductions and the tax credits that the marketplace provides the avenue for. You can see the slice of Oregonians. I think you all know this on the Health Policy Board. This is really an avenue for folks who whose income is a little bit too high for Oregon Health Plan, but who don't have employment-based coverage or Medicare coverage. And then you can see the last couple of bullets there. Who is covered, and we'll talk a little bit more about that later. Shannon, I wonder if you, we didn't script this, but I wonder if you could talk about as a practitioner in the field, you see which Oregonians this program serves.
Yeah, well, and I just want to talk a little bit about the Oregon Health Insurance Marketplace as a whole. We're a state-based marketplace, but we use the federal technology. What we get out of that, though, is really support on the ground locally. We have a wonderful team in OHIM where they support clients who have really complex cases, kind of get that ground level support. They also are a wonderful resource for agents in the state of Oregon, as well as navigators, so assisters who help people navigate the landscape. And I can say personally, it's wonderful to have ground level support. Health insurance is ridiculously complicated, and knowing we have somebody that we can turn to when we need help to advocate for our consumers is great. They provide an invaluable resource for Oregonians.
Annette, next slide, please. Go ahead, Shannon.
Oh, yeah. So what is the Marketplace Advisory Committee? We're a group of individuals who advise in governance and operation of the health insurance marketplace. We meet 5 times a year. We were, as Dan mentioned, formerly the Health Insurance Exchange Advisory Committee, where if we can maybe go to the next slides, that gets into kind of individually who we are. And sorry, Dan, I'll let you.
You're on a roll.
We have a wide range of stakeholders. Insurance companies are represented, insurance agents, community leaders, small business owners, enrollment assisters. We also have some geographic diversity with Eastern Oregon represented, Portland metropolitan area. So really trying to find that blend to make sure Oregonians as a whole are well represented by our membership.
And just a note, Jen Wielander there at the bottom has rolled off. So she's no longer on the advisory committee. Go ahead, Annette. Yeah, so here you can see really what our focus is. Regulates the filing of plans and does rate review of the plans. So fortunately, we don't have to do that, but we have a very close partnership with DFR, and we stay really in step with them throughout the year. And we won't go into the numbers here, but I would just say, I think all of us and Chicky and the team are really proud of the fact that some of you may remember a few years ago, there were counties in the country that were at risk or actually did go bare, meaning there were people in this country who did not have access to those federal subsidies because their county did not have a health plan that was available to them. We went right up to that precipice there, and thanks to good work of Pat Allen and others in his prior role and others at DCBS at the time, we avoided that. And today we actually have very robust offerings. And I think every county, Shannon, has at least 2, and in many cases 3+ plans. Is that right?
Yes, that's correct. Yeah, which is wonderful.
We've talked about the second bullet. One of the things that if we have time, Dr. Bangsberger will get into is the functionality and the operational flexibility question, because I do actually think that's a big issue for the Oregon Health Policy Board and OHA in the future. If we are to achieve our goals of expanded coverage and of integration, and creating a better system for Oregonians, we really have to think about the platform that the marketplace is on. And that's probably a bit beyond our discussion today. But we are on a state-based exchange, but it's operated on the federal platform. And that platform there you can see is healthcare.gov. Many states originally set up their own state-based marketplace. Others just didn't open exchange at all, and we know which states those are. Some of the states that declined expansion altogether. And then remember, there was a middle group, and Oregon became one of those, where we opened a state-based marketplace, but we're doing it on the federal platform. So it's sort of a hybrid, and there's really just a handful of states in that hybrid model. And what I want to leave you thinking about today is that several states, including Nevada, Maine, New Jersey, Pennsylvania, and others, have now moved off of the federal platform and have created their own state-based platform. The technology in the private sector has advanced significantly in the last 5 or 6 years, and states are now leaving healthcare.gov and starting their own platform. And the reason that's important for us to think about is being on the federal platform gives you limited functionality. It does not give you robust access to data about enrollees, which will be critical for us as we think about the connection between Medicaid and group coverage, as we think about how a public option would fit in this ecosystem. We simply won't have access to the data we need to make an informed decision. We're limited in the type of customer support that we can provide through the federal marketplace. We're limited in our ability to do special open enrollment periods. We're kind of hitched to the federal enrollment periods, and we don't, unlike other states on their own platform, we don't have the ability to draw our own open enrollment periods. So again, probably needs to be a more robust discussion in the future, but this is a critical decision for the MAC and the Health Policy Board and the Oregon Health Authority to make in the months and years ahead. And we did, just for reference, some of you know this, the Marketplace Advisory Committee did prepare a pretty formal, thorough, I think, letter back in September of 2019, so just about 2 years ago, documenting the need to move off of the federal platform and onto a state-based platform. Chicky can provide that letter to the committee if you're interested. It goes into much greater detail than I was able to just now about the benefits of moving to a state-based platform. And so we've done that work. We did, as I said, we did it 2 years ago. It's out there, and now it's really up to the Health Policy Board and ultimately the legislature to help us make that transition. I think we'll maybe next slide, Shannon, you can take it.
So where are we kind of in alignment with Oregon Health Policy Board and OHA? The strategic goal to eliminate health inequities by 2030, the priority to advance health equity, and then a focus on getting more Oregonians insured and providing them with options for coverage. The Oregon Health Insurance Marketplace really does some targeted outreach and education for Oregonians with their network of assisters and partner agents. And they really are able to kind of drill that down because we have that local support on the ground through the Oregon Health Insurance Marketplace to make sure things are culturally and linguistically appropriate, and find out where are we missing folks, where are people at who could be eligible for coverage and who aren't signing up for coverage. And it's great to see that work on the ground and know that we have that support here locally in the state of Oregon.
One of the hallmarks of what the marketplace staff does, not necessarily the advisory committee itself, but, and Shannon, I know you can talk about this, is, and this I think is unusual for this program, is there's a lot of working directly with external partners. There's been some grants made over the years to support external partners in enrollment, very culturally specific, targeted at vulnerable and hard to reach communities. And I don't know, Shannon, if you've seen some of this in play in your work and how this has brought people into enrollment that might otherwise be missed.
Yeah, you know, I think Oregon's priority of supporting people locally on the ground, I think local community members know best how to support their communities. And so prioritizing that with funds to allow these organizations to do outreach and fund specific work to reach people who are eligible for coverage has been wonderful. Another item that they provide is just collaborative. So there's a monthly collaboratives that span the whole state of Oregon that's facilitated by the Oregon Health Health Insurance Marketplace, DCBS and OHA. It's an opportunity for people to come together to find out what is going on, how can we best support our communities, and again, kind of that local folks know best how to support their local community members, and that's where they've been focused. It's wonderful.
I've also been really impressed at some of the targeted advertising that they've done in different languages and the outreach. And again, not for today, but maybe at a future meeting, we can review the annual advertising and outreach campaign. In addition to some of the tactics that Shannon highlighted, there's been some good work done just to reach out to people and make them aware that this is an option. So Annette, one more slide, please. So looking ahead, after we approve the bylaws, there's some things here, and again, we won't go through this. Our next meeting, by the way, is next week, October 14th. And I think, Jeremy, you're going to present the public option, sort of an interim update there. So just wanted this group to know that we're keeping an eye on the public option and Jeremy together. So we'll be getting that presentation and really thinking about how the public option might or might not fit effectively within other individual plan coverage options in the exchange. The third bullet, I just want to highlight that from my perspective, working for Kaiser Permanente, which is very active in PEB and OEB, and we understand the long-term goals of PEB and OEB, which of course is another, a whole nother part of the Oregon Health Authority. But I think one of the, and I can't speak to Jeremy and Pat and others, but I think one of the driving forces of strengthening the alignment of the marketplace in Oregon Health Authority was the ability to do exactly what you see there in that third bullet, which is think about the marketplace in the context of other state purchasing programs. State, obviously, between state employees and Medicaid, Oregon Health Plan is spending billions of dollars, state and federal dollars a year. And yet we, until now, really have operated those as separate programs. And I think the vision of being able to finally implement some of our long-term objectives across programs, I think that's realized now with our move as a state to put earlier this year to put the marketplace in with PEB and OEB and in with Oregon Health Plan in the same agency under shared leadership and under shared oversight of the Oregon Health Policy Board. You can see some other a little more tactical things related to redetermination and open enrollment. But Shannon, any other comments on long-term vision here?
No, just I kind of echo what you said, but from the OHA and Oregon Health Plan side, that Medicaid redeterminations, there are going to be a lot of folks over the 2022 who are going to need to be redetermined for Oregon Health Plan, and having Oregon Health Insurance Marketplace and OHA more close, I think will be wonderful for clients. We've talked often in our committee about churn, right? When folks move from Oregon Health Plan into Marketplace plans, that's kind of a difficult transition. So having that together will have more alignment and hopefully benefit folks not dropping off of coverage when those redeterminations help, or when those redeterminations come through. And then lastly, open enrollment 2022, a lot of changes with the American Rescue Plan Act, and that's rolling right into 2020. As well. So we're excited.
Dr. Bangsberg, we do need to approve the bylaws, but I would suggest your discretion, of course. I would suggest if there are any questions about the materials, that maybe we do those first, and then we'll let Chicky lead us through the bylaws changes.
Sounds good. Any questions or comments from the board at this point? Bill.
Hi, thanks very much, David. And Dan, it's good to see you. And
good to see you, Bill.
Good to, it's great that this Marketplace Advisory Committee is moving forward like this. It's very encouraging to see. I thought this was great presentation. Just one suggestion on this last slide. I think leveraging the state's health coverage purchasing power, aligning with PEB and OEB, makes tremendous sense. I would encourage you also, maybe you're already doing this, is to try to align with private sector purchasers as well, large employers in particular. So that there's a consistency in terms of things like performance measures, payment models, and so on. I know there are other venues where those things are addressed, but I think alignment not only within public sector purchasing programs, but also with private sector could be enormously powerful and influential.
One of the interesting, but kind of ironic things has been it's really the state of Oregon that's led the way in some of those areas. There have been attempts, as you well know, Bill, to align private sector purchasers, but really the state and PEB&OEB in particular, and Oregon Health Plan, that have started to set the pace in terms of quality measure and patient satisfaction. And I think the state's purchasing power is unrivaled by anybody in the private sector, obviously. And so the state's ability to set those long-term goals is, I think the private sector in some ways is counting on the state to provide that leadership.
Pat and then Brenda.
Thanks, Dan, Shannon, thanks for the presentation. Good to see you both again. Just a comment for the board. The point was made earlier in the presentation about sort of lining up on OHPB and OHA priorities. And I think you've seen evidence of that in our discussion about the 1115 waiver. The marketplace doesn't really have, de jure anything to do with that waiver, but the marketplace plays a prominent role in our discussion about how to manage transitions and how to achieve providing as close to 100% coverage as we can. And I think what you're really beginning to see is sort of this net drawing around all of insurance and stopping thinking about these different separate segments that don't have a lot to do with each other, and really thinking of them as how do they fit together as a single system for how we make sure that Oregonians have access to not just health insurance, but access to healthcare and access to investments that improve health.
Thank you, Pat. I think I would really like to see this integration. I think it's it's really nice to see the synergy. Brenda, do you have a comment?
Pat just spoke to it. It was a question around the 1115 waiver and the integration. So thank you.
All right, great. John.
Yeah, welcome to OHPB, you all. This is really great. As you all spoke, I recalled a presentation I heard on public radio in the last couple of weeks about the rate of medical bankruptcies. And there was a study released in July about those. For example, it seems clear that medical bankruptcies or bankruptcy due to medical issues are decreased in states that expanded Medicaid. And going forward, I think it would be interesting if you all could figure out any sense of whether states with exchanges and exchanges that have been more or less assertive have had any effect on the rate of medical bankruptcies.
Yeah, thank you, John. It's good to see you. And that's, I think anytime you have a state that's worked hard to expand coverage, whether people fit into OHP or into the marketplace with the subsidies or any other kind of coverage, you're gonna, by definition, you're gonna lower medical bankruptcies. The other thing that Oregon has done, and I don't know if the committee has talked, if the board has talked about this separately, but legislature recently passed some community benefit requirements that include some charity care minimums for hospital systems. And many of the provider systems in Oregon have implemented those. And that creates kind of a common floor of charity care assistance for people. And so it's a bit of a web to make sure that if people are covered, we now see, high cost sharing plans that can still drive people into financial distress. And so the charity care minimum standards will hopefully backfill some of that. So I think the state has kept a good eye on that. It's not perfect. We know that particularly low-wage workers who are on an employer-based plan that has high cost sharing. And again, I'm looking at Shannon nodding. She probably has these people in her office on occasion distressed about that. So our work isn't done, but I think we've started to create a stronger web for people who are low income.
Thank you. Shall we move on to the bylaws?
Chicky, are you going to walk us through the bylaw changes?
I would be happy to, and I just wanted to check with Annette if we will be perfect. Projecting. Good morning, everybody. My name is Chicky Flowers. I'm the administrator of the Oregon Health Insurance Marketplace. I have been with Oregon Exchange since 2013, since its first open enrollment season, and was fortunate enough to follow the exchange to DCBS and have been serving in the administrator role for the last 4 years. As you all know, Senate Bill 65 transfers the Oregon Health Insurance Marketplace from the Department of Consumer and Business Services to the Health Policy and Analytics Division of the Oregon Health Authority. So the marketplace bylaws, you will see these changes highlighted in yellow. Most of it is cosmetic. A lot of it is also very few substantive changes brought about by Senate Bill 65. Next page, please. So our marketplace bylaws have 6 pages that were approved by the Marketplace Advisory Committee to put forward for your approval. Some of these changes include references to DCBS are changed to OHA. The major or the biggest change to our bylaws, if you can move to page 3, please, or rather page 4, which has Article 3. Thank you. Go back one, please. Oh, actually, sorry, one more, Article 3. So Article 3, Senate Bill 65 slightly changed the committee's membership portfolio. It removed the DCBS director as an ex officio and now asks the committee to have 14 governor appointed, and it sets Senate confirmed members, and only 1 ex officio member who is the OHA director or his designee. So moving forward, OHA's designee is the Oregon Insurance Commissioner, who is Andrew Stolfi, who is also the Department of Consumer and Business Services Director. So my spiel is pretty short and sweet. There's not a whole lot of changes. So we reflected our marketplace bylaws to reflect changes that Senate Bill 65 brought upon us. If you go to the final page, there is a history of changes to our Marketplace Advisory Committee bylaws. And the section, the last bullet, one more page, please, will summarize all these changes to our bylaws. So that's in a nutshell. Happy to have the shortest presentation possible and have Dan and Shannon do most of the heavy lifting. So Dan, back to you.
I'm laughing because Chicky, of course, prepared our slides, our talking points. Her team does all the work. But Shannon and I end up looking good. So thank you, Chicky.
Any questions or comments from the board? Bill.
Thanks, Chicky, for that presentation. A couple of somewhat substantive questions and a couple of other more trivial ones. One is on I'm scrolling through this here. In Article 2, which is I think on the top of page 3 or middle of page 3, describes the Oregon Health Insurance Marketplace as an quote independent unit within Health Policy Analytics Division. What does independent unit mean? Let me ask my other questions and then maybe you can respond to them all. In section 3, just below that, it describes the list of issues that the committee is to provide advice on. I think this is not the intent, but I want to make sure it's clear that it's not limited to these items. That these are all requested, if you will, but there may be other items. I'm thinking about the issue we raised earlier during the slide presentation about the functionality of the existing U.S. The federal government platform and the sense that there's a need to, or certainly a desire, there will be benefits to moving toward a state-based platform that would have more flexibility. That's not reflected here, I don't think, or at least not clearly. So that's my second question. Is it limited to these items or is it broader? Last 2 trivial things. Chiki mentioned that references to DCBS were changed to OHA, but I saw just below that section 4, there's a reference to DCBS, and also section 4 in Article 3 also still has a reference to DCBS. Maybe that's intentional. I'm just a little confused. So that's all my questions.
Let me take your questions kind of from the last one to the first one. So not that was not intentional. That was an oversight from my team. So our apologies. We will go back and make those changes and bring back to the advisory committee. Well, so I guess my question is for process purposes, do we need to come back to have these changes, these minor text changes back to the committee for approval, or can we maybe is it possible to get a pre-approval that with these understandings that we will make these changes to Section 4, Article 3, and other references that we will make these changes that we can move forward with a pre-approval?
I think pending other comments from the committee and the board, if there's no other concerns, we could do a pre-approval, vote on pre-approval, with the changes understood.
And thank you for that flag, Mr. Kramer. So the first one, the independent unit. Jeremy, do you have your hand up? Did you want to answer that question?
Sure. I thought I'd dive in. That's right. So one of the commitments we made to the staff at the marketplace, as well as legislature and marketplace advisory committees, that we would bring the marketplace unit team over basically intact. That it's about 18 staff that we kind of plug and play, if you will, that they're come over. The idea isn't that we would spread them out across the agency. That's important for a couple of reasons. One, just for sort of stability and transition. The marketplace is functioning really well. We aren't moving it over from DCBS because there was a problem with it. It's really to get at some of those larger policy goals that Dan and Shannon and others talked about. So we want to create as little disruption as possible and ease that transition. The second piece is the team is actually funded separately, not from state general fund. It's funded directly from assessment on carriers. And so from a accounting perspective, want to make sure that we're cognizant of that. So they'll come over as their own team within HPA, but what we are doing is really starting to create some alignment internally. And so Chicky and staff with PEB and OHPB are starting to work together on where those points of alignment are. Not merging the teams, but really just starting to look out over the next couple of years and say, okay, how do we start to align our expectations of health plans across these markets as an example? Down the road, obviously, we'll see how things transition, but really wanted to get a couple of years under our belt without any major disruption to the team.
Thanks, Jeremy. That's very helpful for clarification and makes total sense. What you described is kind of a distinct, separately funded unit. Independent unit, just in my mind, implies that there's some kind of independent decision making and policy making, and maybe that's other people read it not that way, but you might want to think about something so that independence doesn't apply. Don't get tangled up some point a year from now where there's some significant policy issue that the head of running the marketplace doesn't feel that she or he has kind of independent authority to make policy changes.
I think that's a really good point, and distinct is maybe a word that we do want to consider, or that you all want to consider as an amendment going forward. I think it is different than PEB and OHPB, which have independent boards, and there really is an independence element there that doesn't exist here. I think that's a great call.
So what was your middle question about the state-based platform consideration?
Well, in Section 3, just below that, lists the duties is to provide advice, and it lists a series of issues or activities. And I just wanted to make sure that wasn't a list that limited, that they weren't limited to these items, that there were other things in terms of and then as an example, the functionality of the existing platform might be something that the advisory committee would want to weigh in on. And I'm not sure it's listed here. There may be other things too. I just didn't want the Marketplace Advisory Committee's duties to be limited inadvertently to this list.
So I'd be happy to take that. So Section 3 and Article 2, Section 3, those very specific items are provided by Senate Bill 65, Senate Bill 1 and Senate Bill 65. The limitation does not exist because if you look at section 1, it says the committee will advise the director of OHA on development and implementation of the policies and operational procedures governing the administration of the marketplace. So this is broad enough. The legislature made this broad enough that the advisory committee can provide advice on the various things that would make our operations efficient and effective.
Good. Thanks for that clarification. That makes sense.
Thank you, Bill, for raising those questions. Other questions or comments from the board?
Dr. Bangsberg, I do have a question. What, and I apologize if Chicky and Jeremy and Pat have already talked about this, but it might be helpful in this setting to talk about going forward. How do we actually start to bring the other Marketplace Advisory Committee members into the conversation? How do we integrate with the larger conversation that the Oregon Health Policy Board is having? What I want to avoid is us becoming, falling into the routine of just doing a kind of a transactional report out or update. I think the Marketplace Advisory Committee has really good expertise. You could hear even from Shannon, the voice of experience there, and the way, you know, she's dealing with her clients and the learnings that brings back. We want to now bring that back to the Oregon Health Policy Board and be able to inform your broader discussions. And so, don't mean to put anybody on the spot, but maybe we can think about how to create an ongoing dialogue between the Marketplace Advisory Committee and the Health Policy Board.
Well, maybe that's a good retreat discussion, how we bring this work together with the waiver discussion, with the cost growth containment discussion, because I think these are all highly interrelated.
Yeah, and public option and others,
Yeah.
absolutely.
It's a very, very rich discussion, but I really appreciate you raising that. I think we should, you know, flag that for, you know, more detailed discussion on how we achieve this integration. Any other comments?
So Chair Bangsford, if I may, just to summarize the changes that we discussed for the Marketplace Advisory Committee bylaws, will include for Article 2, Section 2 to replace the word independent and change it with a distinct unit within the Health Policy and Analytics Division of the OHA, and then really going through with a fine-tooth comb, an even finer tooth comb, to change any references to DCBS to OHA. And these are all for your pre-approval, along with other changes that are already highlighted.
That's how I understand it. Yes, thank you. John?
Yeah, just two comments along the lines that I think Dan was articulating. I assume there'll be a liaison from OHPB to the Marketplace Committee, so that's one way that information can. And then, you know, given what a priority equity has been for OHPB, I think the Marketplace Committee could certainly begin the process that we've all gone through around, you know, educating ourselves and a continual way around the importance of equity in all we do.
Great suggestion, John. Thank you. So we are approaching, I think, the time that we should entertain a motion to approve these bylaws with the changes that Chiki outlined, changing independent to distinct and OCBS to OHPB. Do I have a motion to approve the bylaws with those changes?
I'll move that just to clarify the changes from DCBS to OHA.
Oh, thank you. Yeah, thank you, Bill. Yes.
So moved.
Any other discussion? All in favor? Aye.
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 Any opposed? Any abstain? Great. The bylaws passed unanimously. Thank you, Dan, Chiki, and Shannon for a great presentation discussion. I really appreciate the board's input on this, and we will move on to the next agenda item.
Thank you.
Which is the final. Our next agenda is the final findings and recommendations from the committee membership project. We welcome back Ignatius Bao and Susan Otter to share the committee membership project's final findings, recommendations, and their report, as well as next steps for the project in this important work. This is for discussion, which does not require a vote. So Ignatius and Susan, we welcome you to in your presentation.
Good morning. I think I'll kick it off and introduce myself and ask Ignatius to introduce himself, and then we'll get started. I'm Susan Otter. I'm the Director of Health Information Technology for OHA, and in other duties, I'm lead staff on the committee membership project. Ignatius, would you like to introduce yourself?
Good morning, everybody. I'm Ignatius Bao. I'm a independent health equity consultant, and I was brought on to support the staff in implementing this project.
Great. Let's go to the next slide. So as you may recall, we came to the board in the August meeting to present our preliminary, for Ignatius to present preliminary findings and recommendations. Today, we're here to provide our final draft report, recommendations and findings, and talk about next steps. So we'll start by recapping the work, the charter and the project. Ignatius will walk through the findings, which are largely unchanged from the draft, and then the recommendations, which have been updated and revised based on new work that he's undertaken since we met with you in August. And then we'll talk about the project next steps. I look forward to your discussion. We'd like any additional feedback on the findings and recommendations. We'll be finalizing the report, polishing the formatting, and having that back to you at the end of October. So there's one last opportunity to make any final changes. And then just a preview, we'll be proposing to continue the work group and sponsors through February and come back to the policy board at the February board retreat with some of the next steps we'll be talking about. Next slide. So I'll start with just a quick recap of the work itself. As you know, this work is a part of our commitment to health equity at OHA and the policy board. And here you can see many of the evidence that we've committed to health equity, and that this is one of the key priorities for the policy board. And all of our work in equity is centered in the health equity definition that's on this slide as well. Next slide. So as we think about the committee membership project, we're really focused on the scope of the policy board and its committees, and improving the representation of members on committees that have health equity expertise, lived experience or cross-cultural experience, and representation across the great diversity of our state. Just to orient to the committees, as you know, you have now 11 committees under the Health Policy Board. This is the old diagram that's in the report that shows the 9 committees that you had before the legislative session approved the Behavioral Health Metrics Incentives Committee and the Health Insurance Marketplace Advisory Committee, which are moving under the board as well, bringing the total to 198 member positions across the board in its committees. You can see on this slide as well that each committee has in their statute or charter a specific appointing authority. And in 4 cases, the policy board appoints members, which are the sort of orange-yellow circles. In 4 cases, the governor appoints members, which are the blue. And in 2 cases on these committees, OHA appoints members in the red. Next slide. So the work group was chartered by the policy board after a presentation last September from one of the board's committees proposing a slate that where the board had a lot of concerns and questions about the representation and diversity of the members proposed. And really, the policy board asked OHA to look at this more broadly and ended up approving a charter in December to carry this work forward, to inform and develop a process to ensure diverse and equity-focused committee membership, provide guidance on best practices for recruitment and retention, and recommendations for systemic changes to support diverse and equity-focused committee membership. Since then, we've convened an internal work group, a cross-agency work group Our executive sponsors are Don Jagger, Chief of Staff, and Leanne Johnson, Director of the Division of Equity and Inclusion. And our 4 policy board sponsors are John, Oscar, Ebony, and Brenda. Thank you again for all of your work. We were able to bring on Ignatius Bao as an external contractor in the spring, and he got to work right on environmental scan work and interviews, and produced the draft report, which we presented in. Proposed a phase 2. That initial phase focused on race and ethnic diversity in particular, really focusing on that. We heard right away was we needed about inclusion and equity as well as other elements of diversity. So we improved on the last few additional and environmental scan and research, looking at other dimensions of diversity across sexual orientation, gender identity, disability, age, language, different languages spoken, and some deeper work on practices for inclusive and equitable practices for committees. And so it's with those additional interviews and input that we have an updated final draft report for you today. Next slide. So as part of the work of that Ignatius undertook, he conducted 30 interviews with external partners, including 16 community partners, which are listed on this slide. And if you go to the next slide, I believe it's 14 healthcare and public health partners. And then in addition to the external partners that were interviewed, Ignatius interviewed internal staff, policy board sponsors. It is the feedback, if you go back to the prior slide. One of the things we also undertook in phase 2 was to really prioritize the voices we heard from the community stakeholder interviews in the recommendations and in the organization of how we're proposing to continue and carry out this work. So you'll see that reflected throughout, but we really heard loud and clear that we need to elevate the voices of community as we look at carrying this work forward. And the final report presents really the full feedback we heard from these community voices in those themes that led to the recommendations of this report, as well as feedback from healthcare stakeholders and internal folks. So next slide, maybe 2 more slides. And I think I'll turn it to Ignatius to walk through the findings.
Great, thank you, Susan. So next slide. So these are the findings that are largely unchanged from the draft that we presented in August, but they have now been bolstered by the additional interviews, as Susan referenced, with additional community partners focused on the other elements of diversity, as well as more questions, including internal interviews with OHA staff across the agency around inclusive and equitable practices. And so really wanting to set that even though the title of the charter and the work group is about committee diversity, that diversity is only one step in this process of diversity, inclusion, and equity. And that if we're just focused on looking at the composition of committee members, we're missing the mark. If we're not engaging in inclusive practices of how those committees operate, how the meetings are run, how the voices of community and those impacted by OHA policies are listened to and taken into consideration in decision-making and policy making, and then ultimately to align with the broader goal of the Oregon Health Authority and this board to really focus the work on equity and really begin that very, very hard work of redistributing the resources and power that is so entrenched, that is part of what we're trying to overcome through the commitment to equity. Next slide. And so we want to reiterate that one, the scope of the work, that structural racism is still the fundamental challenge that we're trying to overcome, and that we want to continue that priority focus on racial and ethnic diversity as we move forward, while considering the multiple and intersecting identities that Oregonians and all people bring. And so in this additional work, we looked at the additional structural barriers that are faced by individuals who speak languages in addition to English. Those are obvious in terms of communication barriers, the barriers that LGBTQ individuals may also face, including the social and other kinds of discrimination that continues to persist and for which there are often no legal protections, the physical and social barriers that individuals with disabilities face. And now that age has been added to the definition of health equity, also particularly thinking about the impact on youth and the impact on seniors and elders, appropriate to the former discussion of aligning all payers and thinking about how that intersection between Medicaid and Medicare, for example, might impact on policies. And so part of the additional root analysis, the root cause analysis and gap analysis that I did was really highlight these additional barriers, these additional structural challenges that diverse individuals face, in addition to the racial and ethnic barriers that communities of color face in Oregon. Next slide. So we recognize that the current process was not particularly aligned or coordinated or consistent. And so we were already moving, as we will talk about next steps, of having certainly more communication among the recruitment efforts and ultimately more consistent messaging, outreach, using common tools to collect data about the demographic background of potential committee member applicants, and being able to, again, look at that across all committees for the board and others to analyze to see what kind of progress we're making in terms of diversity, inclusion, and equity. Next slide. We also recognize that this is not just about race and ethnicity data, but that we need to collect all these other types of data. We'll talk a little bit about the sector representation and potentially needing ways to identify how people are representing different parts of the community, both healthcare as well as health and public health, and how, again, we want to balance that so that, again, the voices of community, the voices of consumers, the voices of Oregon Health Plan members are not lost in that. And that we also want to focus on this question of lived experience or cross-cultural experience that is really important, that, again, has not been consistently asked about. Next slide. And so one of the big recommendations that we're making is that we're going to propose these definitions of lived experience and cross-cultural experience. Lived experience based on one's self-reported identity or identities, and cross-cultural experiences based on experience one has working in populations in communities other than one's own identity, which is also valuable to bring, and needing to bring all those types of expertise into the work of the committees. And so we'll be having more standardized questions about this and being able to look at the data as it comes in from potential applicants. And then finally, the last finding, we recognize that this is a process. And so we recognize that there are also barriers on the community side, and that partners in the community may not have the capacity to serve on all 200 OHA committees, or even now all 11 of the Health Policy Board committees. And so there may need to be more structural support for that increase in diverse representation, that many are not compensated for the volunteer time that they would be putting into serving on a board. And certainly making sure that when we return to in-person meetings, that things like transportation and even childcare and food are also budgeted for and provided. Next slide. And then finally, we recognize on the OHA and the committee side that this is, again, a multi-dimensional process. It's not just putting these types of processes and procedures in place, but there also needs to be training and support for both the staff at OHA that supports the committees, as well as the committees themselves, to really understand and operationalize and implement the kinds of recommendations for inclusive practices and ultimately equity. And this requires those committee staff members and committee leadership in particular to be conscious and do things like exit interviews to find out what barriers members may have faced in serving on that particular committee. Next slide. So we've organized the recommendations next, as Susan mentioned, slightly differently to really prioritize the feedback that we heard, particularly from community-based partners, as opposed to healthcare and public health partners, even though we incorporated everybody's feedback, but we really prioritized. And so one of the things that many community partners said was, even before you get to a conversation about committees, we want to know how those committees, how OHA is engaging with us. What's that relationship like? Is there trust? Is there any kind of bi-directional relationship that already exists? That there certainly needs to be more and clearer communication and information about the committees and what the committees do. That we do want comprehensive and disaggregated data about committee members and applicants, and that there may be some ways that we can more intentionally support the retention and participation of those diverse committee members, and not doing business as usual by having things that I'll talk a little bit later about, like language access and other kinds of communication access. Next slide. What external partners also emphasized was that ultimately this is not just about changing the numbers of who sits on committees, but that there really need to be more systemic changes in how those committees operate to make sure that they are moving beyond diversity to inclusion and equity. And that many of these are going to require practices, including public comment practices and decision-making practices, and that again, folks from the community also recognize that staff and committees need training and support to do this. Next slide. So we've reorganized the recommendations now into 4 recommendations. The first is that that engagement needs to come first, even before we get to a conversation about committee membership, that all committees should be looking for opportunities to listen to engage, to work with communities that are impacted by their decisions and policies, particularly those diverse, underrepresented, and excluded communities, and that there are ways to do that even before bringing any of those representatives of those communities or members of those communities onto the committee. Next. And then affirming the charge of the work group in this project is that there are ways to increase that diversity by coordinating recruitment, by standardizing the collection and reporting of demographic and sector data, again, making sure that we're not overrepresenting certain voices and that we're continuing to elevate the voices of communities and consumers that are most impacted by those policies, that there are affirmative ways to support retention, and ultimately some of this may require changes to those authorizing statutes and charters. Next slide. And so in this final draft report, you will see many more recommendations and discussions of existing practices of that some OHA committees and other parts of OHA and just engaging with community have started to implement. Some of it deals with how to make virtual meetings more inclusive with things like language access, with ASL interpreting and captioning. Others involve ways in which the choice of venue, when there are in-person meetings are chosen, can be highlighted and made more accessible. The time that the meetings take place also makes a difference. And then within any kind of meeting, really highlighting, as this board has now done, of moving public comments up front so that folks are able to weigh in before decisions are actually made. Other ways to highlight and even affirmatively invite input from the community into the deliberations and the discussions so that those community voices are elevated. and then ways to practice more inclusive decision-making to make sure that before votes are taken or as votes are taken, that all committee members are heard and have an opportunity to weigh in. Next and final slide for me is then ultimately this is work that will need to take place over a long period of time, because it really is the work of moving the Oregon Health Authority and the board and its committees towards equity, is that there needs to be support and training about diversity, inclusion, and equity, that there are many tools that are out there that have been recommended for both government agencies and in the community and private sector. And those have not necessarily been adopted formally by OHA or by any of the committees. And so a lot more discussion and decisions about how to adapt and adopt and operationalize those tools. But ultimately, we want to get to a place in which equity is part of every decision and policy. And the good news is that there are some practices. So you will see a presentation coming from the Health Workforce Committee following this, in which they've actually taken some of these tools and created a health equity framework. And so that's something that other committees may want to do. There's prior examples of the metrics committee, the health plan quality metrics committee, looking at the metrics that have been used for the CCOs in the past and applying an equity analysis to them. And so that is another tool that could also be used by other committees. And there are many other tools out there that are now included and referenced in the report to make sure that we are helping the committees and helping the OHA staff move towards equity. So I will end there and turn it back to Susan to talk about the next steps.
Great. Next slide. So our next steps are to finalize the report, as I mentioned. As we look at implementation, we're focused on right away our standardized survey for demographic and sector data for committee applicants and members. I think I'll talk about that on the next slide. We're building the systemic processes for committee member recruitment. That includes carving out time for some of our staff positions that are dedicated to, will be dedicated to coordinate across committee member recruitment, and bringing on new positions that'll include a component that focuses on outreach to stakeholder external partner groups to start to build some of those relationships and direct connections, and start to build, interest and leads around committee work, potential committee members. We'll be implementing and updating guidance for committee staff and leadership on inclusive practices and developing a training plan. That will pull from a lot of the resources that Ignatius has added into the report around inclusive practices and equitable practices as well as keying into some of the folks that are already doing this work in other OHA committees. And then we'll be doing some analysis to make recommendations around statutory and charter changes. Many of the barriers we have in committee recruitment are because we have very specific statutes that dictate the specific members and in some cases. And then our communication and rollout plan with the committees is part of our immediate next steps. Next slide. So just a note on the demographic and sector data survey. So we had started planning this back in July when we previously reported to you. We developed the draft survey with staff and sponsor input and are currently pilot testing a common demographic and sector data survey with the Health Equity Committee and Cost Growth Target Advisory Committee recruitments that are open right now. So if you're interested in seeing the draft survey, you can go to sites for the Health Equity Committee or Cost Growth Target Advisory Group, and the recruitment survey is part of those websites. We will be reaching out to all of the applicants to those committee recruitments with an anonymous survey to get their feedback about their experience in completing the demographic and sector data questions. And we'll use that as well as other input we've received across staff and sponsors to revise and finalize the survey. We plan to then roll out the survey data collection to collect baseline data for the policy board and all of its committee's current members so that we can report back that baseline data at the February policy board retreat and give the policy board a better sense of to what extent you have individuals that have health equity experience already represented on committees or lived experience, cross-cultural experience, or different demographic or sector comparisons. And in the green box, you can see the major sections of the survey in the order that it's currently in the draft survey. We will be putting the final survey in an online survey tool as well. And so we're getting ready for that. Right now, the pilot testing is on paper. What we found, though, is that we'll need to have the survey available on paper and even potentially available as a phone interview for some of our applicants, depending on their comfort or ability to access an online survey. So we're learning a lot about how we can roll this out through the pilot testing. Next slide. And then the last piece I wanted to mention, so our project next steps are to finalize the report and share widely. We are already reaching out to beyond the policy boards, committees, staff across our HPA committee leads will be reaching out later this week as we want to make sure that the results and recommendations of the report are widely shared and that we start to coordinate across all committees, not just those of the board. We do look for any final feedback by October 22nd, so we can finalize the report by the end of the month. We are planning to continue the work group, our internal work group, and our sponsors through February, which we really see as this implementation phase. We will be bringing on new resources. As I mentioned, we have a couple staff positions where we've carved out time or resources to dedicate to continuing this work. And we've been able to continue Ignatius' contract as well. And then we'll continue the implementation work. The committee data piece, as I mentioned, will be sharing the results back. I went through that as well, and bringing you an update on all of this work with those baseline results at the February board retreat. Next slide. I think I'll hand it back to Ignatius for discussion.
Great. So we're looking forward to any feedback. We know that this was a really lengthy report, as some of you have seen different iterations of it earlier. This first question is there anything missing that we should emphasize in the final edits and formatting? And then obviously welcome any thoughts on how you might assist in, as Susan said, spreading the word in your role as liaisons to the various committees in terms of how the report and its recommendations might be taken up. So I welcome any comments or feedback or questions.
Thank you, Ignatius and Susan. It was great progress. Really appreciated reading the report. There's a lot of thought and work has gone into this. I'd like to open this up for discussion or any questions from the board. I have one question. I mean, clearly the success of this will be in your recruitment strategies, your ability to get the word out there. What do you recommend to us and to others in terms of best practices in terms of recruitment?
So I think you're already starting to see part of the list of community partners that were consulted. If you again look at the upcoming presentation by the Health Workforce Committee, you're going to see a lot of the same names of organizations. And so I think part of what we're recommending is, tools like a relational database so that we keep track of how those contacts are being made so that when there's turnover, even internally at OHA or turnover in the community at the partner level, that there's some sort of history that's documented. The other is really recognizing that we don't want to overload those partners and keep going back to them and asking them the same questions over and over again. And so again, I think conscious of continuing to identify additional partners that aren't in people's networks. Oregon is a big state and a very diverse state. And so really trying to reach beyond the usual suspects in the usual networks and continuing to expand that. And you can only do that by, again, setting a baseline of who you want to turn to first, but that you need to continue to make those efforts over time to keep reaching out into other areas and to other partners.
Very good. Thank you. Oscar?
Sure. I think comment, a question, and then a comment. So I just want to say thank you again for all your work and dedication on this report. I'm very impressed by it. It's very thorough. It really shows that the entire team took this very seriously. I really appreciate this, the conversation about this is more about diversifying committees, right? Like diversifying is sort of like the first step in like a series of many, many different steps that have to take place to actually be able to do this work successfully. So yeah, I'm very grateful for this really thorough analysis. I have a question. We've talked a little bit about the retreat, and in your slides reference, sort of reviewing some of this baseline data in February. I'm curious if you've had any thoughts or conversations about like what we will, what success would actually look like, right? Like I think that once we have this baseline data, it could really sort of ground us one way or another in terms of what success may be like. But I'm wondering if there's anything that we could do ahead of getting that information to talk about like what do we want to get to, or what does success look like? That way, when we do get the data, we can determine ahead of time, if possible, whether we're like on track, behind, ahead. So thoughts about that. And then my other comment is in terms of your question regarding like the disseminating the report. Just a suggestion, like I'd be happy to use whatever platforms I'm on to be able to disseminate this. Would be helpful to get a little bit of a blurb if possible to just be able to like put that out there. I'd also suggest like trying to get culturally specific organizations to even ask them to share the report to their constituents and their members to try to get feedback from them as well.
So I can take a first shot at trying to answer that question, Oscar. So I think success when we come with the baseline data will be to show we're doing okay on reaching out to Latino community members across the committees, but we're not doing as well in having representation from African American and Black communities. And so again, it's not a committee by committee task to close that gap, but it really then becomes an OHA task across the agency to really look more closely at those community partners and really engage in some honest and maybe some challenging and difficult conversations on what those additional barriers might be. And so I think being able to identify where those gaps are and then take a systemic approach to trying to overcome those challenges and those gaps would be success, as opposed to, again, the way that things have been, which is really the burden on individual committees to say, why isn't your representation more diverse? I think it takes that systemic approach. It takes a humility from OHA to say, we haven't done what we need to do, and how do we do better?
Thank you. Pat, you have a comment?
Yeah, just quickly to Ignatius's last point, I think the pandemic has provided us a really hard and challenging opportunity to really begin having those conversations in some ways that we really legitimately have not before, and they are very difficult. But it's also given us the opportunity to get comfortable with that difficultness and be candid and be able to hear hard input.
Thank you, Pat. John?
Yeah, I'm just thinking about OHPP committees, and I think that would be a very interesting process to get going on that in some way. I'm sure that individual members will wonder, is this saying something about me, or am I the problem, or am I the solution? I think as a committee, some will say, let's go. Others will say, I don't know, let's wait and see. But I think that could be a very interesting process. You know, I think the report's incredible, but we may need to come up with the headlines for some folks who just won't read it. You know, they won't read it. But it has so many incredible nuggets in it. You know, like how the report thinks about lived experience is a headline to me. And so, you know, I think to some degree, beginning that communication process with committees and individual committee members, there will be a lot of learning as they react.
Thank you, John. Brenda?
Yeah, I will echo the previous comments around commending Susan Ignatius, your heavy lifting work. And I very much appreciate the illustration of describing the importance of inclusion, as well as, you know, not just, you know, focusing so specifically on the diversity part of our body of work. My question for you is, as we move into a February retreat, how you and the others are thinking about measurements. So specifically, if we establish this baseline information, as you've described in your report, how are we also content composition? So how do we measure inclusion in material ways? So we can set targets for ourselves in each of our committees in doing so. More of a comment, I suppose, than a question, but definitely on my mind. Thanks.
So I think there's, Brenda, I would say there's, we could use some really simple process measures. And so again, you know, seeing agendas shift where there's, you know, one of the comments was that we know that there's a lot of heavy content that are brought before committees, but how much of that balance of that agenda time is taken up in presentations versus discussion versus really hearing from community partners. And so again, it's not to totally throw out the need for presentation and conversation, but how much of really just the time of how those processes play out would be a simple process measure to say, we actually got more public comments. We actually heard from other stakeholders and partners other than just OHA staff would be one measure.
And I just want to add, I think this is also why we are excited to continue the board sponsor volunteers that, you know, that you've been engaged so far, because I think we'll put some thoughts together, but we'd like to bring that back to you as the 4 board sponsors for this project, so that we are kind of teed up for that February discussion to be really rich and thoughtful. So thanks for the comments and questions.
Any other comments or questions from the board?
Yeah, fun. Thank you so much again. Ditto to prior comments and appreciation for this work. And I guess thinking more about Brenda and Oscar's comment and kind of a combination of the two, like as we think about that, I'm also very interested in retention as evidence of success in this work. So we recruit them, are people's voices heard, and then do they feel like it's valuable time and they continue in the work. So I look forward to the conversation in February. Thank you.
Thank you, Kirsten. All right. Well, very good. Thank you, Ignatius and Susan, once again for this progress and presentation. We're a bit 5 minutes ahead of schedule. We're going to move to a break, a 10-minute break. Tara, do you know, are the next presenters, if we start at 10:25, are the next presenters ready? Find out. Okay. Let's plan to reconvene at 10:25. 10-minute break. All right. Look forward to seeing you all in 10 minutes. welcome back, everyone. Welcome back. Let's see, we have Brenda. Good. Okay. All right. Today we're joined by the Healthcare Workforce Committee staff, Chair and liaison, to hear about the committee's final Health Equity Framework Report and its proposed allocations for the Healthcare Provider Incentive Fund. Brenda Johnson, a member of the Oregon Health Liaison to this committee, and will start things off for us. So Brenda.
Thanks. It's absolutely my pleasure to be the liaison to this committee. I am so struck by the power of the work and the organization that our leaders here bring forward for the state, for OHA, and certainly for OHPB. Today's presentation is going to focus a tiny bit about the history of the committee, its primary purpose. Of course, we'll talk about the equity framework and the committee's efforts to that regard, and specifically about not only the process, the findings, and the themes that were discovered throughout that process, but how the committee is intending to use the equity framework in really practical, everyday ways. And then we'll conclude the presentation with a vote around the Healthcare Provider Incentive Fund and the program, including some shifts in the allocations of funding for this upcoming biennium. It's my pleasure to welcome leaders of the committee, Kurt Stilp, who's the chair of the committee, Mark Overbeck, Neelam Gupta, and Joe Sullivan, each who hold really extraordinary leadership roles within OHA. So welcome, and thank you for coming today.
Thank you, Brenda. Hi, everybody. This is Kurt Stilp. I am the chair of the Healthcare Workforce Committee. And if we could jump to the third slide, that would be great. Yep, excellent. Oh, back one. Great, thank you. So as many of you know, the Healthcare Workforce Committee was established in 2010 as an official committee within the Oregon Health Policy Board. And as its name suggests, its purpose really is to coordinate efforts to recruit and educate and retain quality healthcare workforce across the state. Currently, we have 18 members, and as with all committees, members do rotate on and off for certain segments of time. And this last round, when we were onboarding members, we were very, very purposeful in terms of making sure that we were recruiting and onboarding a diverse set of individuals to serve on this committee. Certainly when it comes to race and ethnicity, but also diversity when it comes to healthcare professions, when it comes to individuals that represent different geographic areas of our state. And so the 18 members that we currently have, we feel like do represent a lot of different voices, a lot of different perspectives, a lot of different individuals that can speak to the work that you're going to hear about today. So just in terms of the committee's background and those individuals that are moving the work forward that you're going to hear about here in the next handful of slides. So you can go ahead and go to the next slide, and then I'll turn things over to Mark.
Kurt, thank you so much. Good morning, Chair Bangsberg and members. I'm going to provide just a few slides of a bit more context for the two items being brought today, the Health Equity Framework and Report for the committee, and also the committee's recommendations to you for the allocation of state resources from the Healthcare Provider Incentive Fund into the Healthcare Provider Incentive Program. So first of all, go to, thank you. Much of the work within OHA to expand and diversify the healthcare workforce has come through HPA's primary care office. And I want to set the stage that work has been undertaken with really a very finite set of resources, ranging from about $6 million of state funds biennially in the 2015, 2017 biennium, which have expanded over time to about $18 million in the current biennium. And those resources have been targeted largely at specific areas of the state and to communities that we have historically called underserved, or you could say under-resourced. And those activities have really included a focus on recruitment and retention of providers in federally recognized shortage areas and providing linkage for those around the state with healthcare employers to those federal resources, along with administering the state-funded healthcare provider incentive programs. Now, it is worth noting that OHA does have some activity related to the adequacy of the healthcare workforce through the CCO contracts. It's not clear that that activity is really set up to do the kind of deep dive looking at specific clinics in the regional area. Their individual workforce needs for the community, those are largely more compliance based, like a met or not met in terms of a definition of adequacy. Thank you. Next slide, please. So with those, we have had successes, and due to our outreach efforts, many healthcare providers have taken advantage of federal health provider incentives. Oregon is consistently among the top 10 states with our 4.3 million population and the total number of awards going to Oregon-based providers out of about only 18,000 providers statewide eligible for those awards are either number 7, number 8, number 9 year after year in terms of Oregon providers taking advantage of that resource. We've also had kind of a win, if you will, that most health professional shortage area scores decreased in the 5 years prior to the pandemic, meaning that there have been improved ratios of providers to populations needing healthcare. And the areas of unmet need scores have generally increased during that time as well. That's a report that's put out by our State Office of Rural Health, and increased scores meaning less unmet need. And then finally, in terms of some wins or some highlights of our activity, we have developed over time strong partnerships with safety net practices, community health centers, rural health clinics, hospitals, professional organizations, and the larger workforce development system. So those are some of the highlights of our efforts with, again, finite resources targeted for specific areas, specific communities. Next slide, please.
Hey, Mark, your sound is a little bit rugged. I wonder if turning off your camera might help.
Oh my goodness. All right. Thank you so much for that. I apologize for that. Let's see what we can do here. Stop the video. How is that? Does that improve the quality of the sound?
Yeah, a little bit.
Okay. Thank you for that. Sorry. Next slide, please. Yeah. So while we have had success pre-pandemic, you could say that 2020, with both the revelation of systemic racial injustice, the emergence of the pandemic itself, has shown that it wasn't great for everyone. And further, here in 2021, we're now dealing with, as you all well know, multiple workforce crises. So I think perhaps the lesson is that although in stable times we have strategies that gradually do improve things for many, we can definitely see that market forces, economic forces, social forces have a major impact on the training, the supply, and the distribution of the healthcare workforce. And even further, these crises have revealed what happens when you have systemic disinvestment in economic and community infrastructure. But then finally, the upside, if you will, because I always like to look on the upside or find an upside, is that this not so happy news does provide us a unique opportunity to reframe and refocus our efforts both within the primary care office and for the workforce committee squarely inside a new equity framework. So with that, I'm going to turn it over to Neelam Gupta to share the work that OHA and the workforce committee have done to develop the framework, the report, and then Joe Sullivan will present the committee's recommendations for allocating resources informed by this framework.
Great. Thank you so much, Mark. I'm here today to, as Mark mentioned, present about our equity framework report. We did an educational webinar back in August and are pleased to come to you today for an additional presentation and review of the report. Just to recap, the Healthcare Workforce Committee has been working to develop an equity framework that aims to review funding recommendations on allocating resources and to consider conversations related to the future of the healthcare workforce in Oregon. And this work really started back in December of 2019 when the Healthcare Workforce Committee was presenting on resource allocations to the Oregon Health Policy Board and was asked whether or not an equity lens was being used to make those recommendations. Those conversations then started and within the committee, and the discussions to develop an equitable workforce delivering culturally responsive care took on an added urgency as a result of the COVID-19 pandemic and all of those larger forces that Mark described earlier. Next slide, please. The equity framework is firmly and squarely anchored in the health equity definition that OHA and the policy board developed and updated last year. Having a health system that creates health equity requires ongoing collaboration, the equitable distribution or redistribution of resources and power, and rectifying historical and contemporary injustices. Next slide, please. The methodology used again was to start with looking at existing community feedback from various reports, needs assessment, and surveys. The intention of doing this was to honor the vast knowledge that already existed and to also minimize listening fatigue, recognizing how stretched and stressed a lot of our community partners are. Based on that analysis, we realized there were certain gaps in our knowledge, and we then proceeded to schedule listening engagements. We were able to conduct 29 listening engagements with a variety of organizations statewide, and all of this was preceded by training in constructivist listening that was provided by the Cross-Cultural Healthcare Program located in Washington on how to really listen deeply for the benefit of those that are being listened to. And then lastly, we also relied on discussions happening with the Healthcare Workforce Committee, some of the conversations we've had with the policy board, and then various PCO reports and discussions. The primary care office collaborated with the patient-centered primary care home program, which is part of a new unit that was established about a year ago that I direct in gathering and analyzing these sources. And then on the next few slides, we'll also present some information on the Healthcare Workforce Committee's recent activity and investments to provide additional context. Yeah, next slide, please. Thank you. I don't want to spend a lot of time on this because I know, again, we reviewed this at the educational webinar, but this is a partial list of the documents that we analyzed initially. Next slide, please. And then this is a list of the organizations, statewide and local organizations, workforce organizations, OHA commissions and committees. We tried to the extent possible to go to existing meetings or to schedule one-on-one interviews. The organizations that you see and the community representatives that you see that are in orange text are listening engagements that workforce committee members participated in. Next slide. And then again, as I mentioned, we collaborated with the Patient-Centered Primary Care Home Program. And so this is a list of the primary care practices and organizations. So as you see it, it's really a very broad group representing different life experiences, perspectives, and geographies throughout the state of Oregon. Next slide, please. And then, just to give some context, some of the recent Healthcare Workforce Committee activity that's taken place over the past year have been in the areas of workforce supply and distribution. We developed the latest version of the Healthcare Provider Incentive Program evaluation that was approved by the board, as well as the recent biennial healthcare workforce needs assessment, and also workforce composition force reports. The committee also had presentations on upstream pipeline development and telehealth. And then lastly, in the area of workforce skills, training and development, we've had some excellent presentations on the issue of clinician burnout and resiliency. Next slide, please. So this slide is a slide that I'm sure you're familiar with, having had it presented in the past. This provides a snapshot of the state and federal funded healthcare workforce provider incentives that are available to Oregon providers. About 25% of the nearly $65 million that was available in the last biennium is through state tax credits to rural practitioners and volunteer EMTs. Another 40% is for state financial resources. And then the remaining 35% is federal financial resources through the primary care office's activity around shortage designations and National Health Services Corps. And then lastly, there's also the state non-financial resources as well through the J1 visa waiver program. Next slide, please. So this is, a summary of what we heard. Really goes, we summarized it into 7 main themes. During the educational webinar, we went into much more detail on each of these themes, but I just want to restate them. The first theme that we heard consistently from stakeholders was the importance of addressing the leaky pipeline and developing career pathways. The second theme was the importance of confronting bias in education, training, and credentialing. Next slide, please. And then can you skip ahead? This slide is actually a duplicate. The third area we heard about was the need to establish inclusive recruitment, hiring, and retention practices to address bias and to create a supportive workplace environment for staff from communities of color, tribal communities, and communities experiencing inequities. The next area was tackling compensation issues and addressing, in particular, structural wage inequalities. The fifth area we heard consistently, again, from everyone we listened to, was the need to create culturally responsive services and practice environments to really create a welcoming practice environment with a workforce reflecting patients served. Next slide, please. The sixth area we heard about was considering restructuring provider incentives, providing incentives to cover upfront education costs, also to provide incentives through wraparound supports, And then the last area we heard a lot about was addressing other issues related to health equity, such as providing professional development to lower wage staff, hiring and retaining diverse staff into leadership positions. We also heard about providing workforce development opportunities for people who don't always get them, such as persons with disabilities. Next slide, please. Based on that, we developed these set of guiding questions that really speak to how do Oregon's healthcare workforce development efforts advance opportunities for communities experiencing health inequities. And in the report, we provided a little bit more information about how we could apply these questions. For example, if you take the first question, who are the racial ethnic communities and communities that are experiencing health inequities, and what is the potential impact of the resource allocation of these communities? We can ask ourselves, what are the possible negative or positive impacts of the resource allocation? How do we know about these impacts? Have we communicated to the community the expected impacts? Next, we can further ask ourselves, how do we measure the impacts? Considering how OHA typically measures impacts, and then asking the community how they measure the impacts, and do they want to be involved in that measurement process? And then, another question we can also ask ourselves too in the application is, how can the PCO be transparent, accountable, and forthright about its targeted workforce programs? How can we explain what we can do and what we can't do? Next slide, please. So, these are some ideas we have about applying the equity framework in our everyday practice. It includes having the health equity definition and the guiding questions in each meeting packet, using the guiding questions to develop agenda items that include best practices and emerging strategies on creating an equitable healthcare workforce, providing presenters to the committee with the guiding questions so that they can use them to develop their presentations, framing the content and recommendations in any reports we develop using the guiding questions, applying the guiding questions to resource allocation recommendations that the Healthcare Workforce Committee makes to the Oregon Health Policy Board. And in the next segment of this presentation, you'll get to experience some of our practice in using that with the Healthcare Provider Incentive Program allocations. And then lastly, continuing to make committee meetings accessible by providing interpreters and other accommodations and as requested. And if you have any other ideas or thoughts or suggestions on how we can do this, would love to hear those as well. Next slide, please. And then, also we really want to continue relationships with those we listen to, recognizing what was covered in the previous presentation, that there are a small group, or not a, I shouldn't say a small group, there, we're tapping people and community representatives multiple times, and so we need to be thoughtful about how we and so we did share the draft report and requested additional feedback. We're considering inviting participation and have released an application for a community leadership council in House Bill 2949's Behavioral Health Workforce Initiative to really make the process community-led and community-owned. And we're also considering other opportunities we can craft to ensure that community voices are not only integrated into the community discussions and actions, but really start to lead our work. And then next slide, please. And then lastly, just want to take a moment to acknowledge that, without the listening engagement participants, this report would not have been possible. So grateful to all of them for their time, offering their community wisdom and expertise to us. And then the cross-cultural healthcare program, who provided the training in constructivist listening. The Oregon Health Policy Board for asking the question that started this process. And lastly, the Healthcare Workforce Committee and our amazing liaison, Brenda Johnson, for embracing this process and their commitment to applying the framework to achieve OHA's 10-year goal of eliminating health inequities. So I'm going to stop there and see if there are any questions.
One thing to potentially add for consideration on the list of moving from policy to action is disparity studies. I think one of the things that's become clear over the last year is that we actually really need to be able to take specifically race-conscious actions in terms of investments or policies or activities, and the legal threshold of strict scrutiny is really hard to get over to be able to do that, but you can do it if you really provide a depth of data around the discrimination that you're trying to address. And looking generally at health disparities, I think we've learned isn't sufficient to do that. And so I think we need to be conscious about making the investment both in HPA and elsewhere in the organization to be able to build the data case to be able to take those kinds of steps in all of our program areas. And I think it'd be good to try to get that on the radar for folks.
Thanks, Pat. Any other comments, questions?
I'm really excited by this work, and it's not only because the workforce development and what that means, but also to see kind of equity ingrained throughout and what that looks like for a committee's work. And I just, committee's been doing a lot of listening and it shows. So thank you for that. And yeah, I look forward to the next report as always with you all.
Thank you, Kirsten. John?
Yeah, I think this is terrific work. At the last Medicaid Advisory Committee, there was a presentation from folks at, I think, DHS, who focus on the developmentally disabled folks. It was, I think, unsettling and stunning to the committee to hear how unstable that workforce is now. I think these are some of the issues that Pat addressed further. And, I just see the work you've done. And, I wonder in a future legislative session, is it time to, take the kind of work you've done and apply it to other worker populations, home care workers, the D&D folks aren't healthcare workers, they're home care workers, and folks in the nursing home, assisted living, adult group home environment, because I think the pandemic is really revealing how vulnerable those workforce populations are. They're probably as important as primary care. Perhaps some thought should be given to doing things for them like you all are doing for the populations you're responsible for. Thanks.
Thank you, John. Kirsten, you?
Sorry, just on that, I guess I had made Oh, I would like to ask a clarifying question about what exactly the populations you are responsible for, because I really interpret it as a healthcare workforce committee. And I know historically this has been focused on how do we really meet the needs of a physician population, and it feels like it's expanded to kind of licensed healthcare workers. But I see reflected in this latest presentation, not just licensed healthcare workers, but considering all workforce across the healthcare continuum. I understand you can't bite it all off at once, of course. But am I wrong in assuming that it's the complete care continuum?
Mark, would you like to take that one?
Sure, Elam. Kirsten, I think your insight is bang on, that we started 10 years ago largely with a physician workforce as the focus, largely primary care. And over the years, this committee's focus really has expanded to licensed and started to move beyond licensed healthcare workforce as well. Community health workers, traditional health workers, the non-licensed behavioral health professionals, which you'll hear just a bit about in the next presentation. I think it's a fair discussion, though, how far and how broad does that casting of the net around the workforce go, and does long-term care, does congregate care workforce, does that equal the healthcare workforce, or is that a distinct grouping?
Oscar?
Yeah, mostly a comment. I just want to say again, thank you for your work in this area. It's really great to see this framework being created, and hopefully, I look forward to other committees adopting similar types of tools. I really enjoyed, sort of the 7 main themes, that summary of the 7 main themes. It really kind of helps make this work a little bit more upstream, right? Like I think so much of the time we get focused on, here's our allocation for this biennium, here's like our budget for the next 2 years, here's the investments that we do, but like I'd really like us to be thinking more forward. And I think that the main themes, if we really look at those very carefully and try to move in that direction, we could become a little bit more upstream on some of these programs that we currently have.
Thank you. Any other comments? We'd like to continue.
All right. So if there's no other questions, I'll just take the first moment of my time to thank you guys on behalf of program staff at OHA, as well as the Oregon Office of Rural Health, for giving us the opportunity to present the 21-23 biennium funding recommendations for the Healthcare Provider Incentive Fund and Program. You can go ahead to the next slide, please. So as many of you guys are already aware, the Healthcare Provider Incentive Program and Fund has been in effect since 2018 as a result of House Bill 3261 that consolidated several separate different incentives into one program and fund. It has been historically comprised of 6 core incentives, all of which we plan to carry forward for this biennium. Here on this slide, you can see the list of the core incentives that have been within the Healthcare Provider Incentive Program historically. Next slide, please. So for this next biennium, the 2021 to 23 biennium, after a small rollover in the about $18 million allocation from the legislature for this period, we have about $19.5 million. As you'll see, the table has a column that expresses the amount of money we expended during the 1921 biennium, as well as a proposal for the 21 and 23 biennium. You guys will see on this is pretty much keeping level funding or increasing in most areas. I'll speak to what looks like a proposed decrease in loan repayment for the next biennium, but is actually a shift to some of the behavioral health workforce initiative work that's happening as a result of House Bill 2949. So if you can go to the next slide, please. All right, so in regards to loan repayment, we would like to keep level funding for a proven incentive that continues to garner interest. We have very competitive award cycles. Seems proven that people are looking for loan repayment resources and are hungry to access those. One of the guiding questions that we use for coming up with this recommendation is how should we modify or enhance strategies to ensure recipient and community needs are met? Through our listening sessions, program staff heard that loan repayment is a critical incentive to the recruitment and retention of providers, and that keeping this at level funding would allow for communities to continue to have access to providers who are representative of the populations that they serve. One thing that we're doing as program staff is continuing to look at the scoring rubric and how we operationalize the program as a whole to ensure that the right people are being chosen for the awards. What competitive cycles means, so we have a lot of people looking for access to these funds, so we can be a little bit more particular and intentional about who we provide the actual resources to make sure that the largest impact on these communities is being had. As I mentioned before, what looks like a reduction in resources for loan repayment is actually a shift of the behavioral health loan repayment to the behavioral health workforce initiative that will be stood up as a result of House Bill 2949 and is happening at HSD as well as HPA. So a collaborative effort being done there and making sure that the subject matter experts can help us phase out the program or tailor it to make sure that it's supporting the work of House Bill 2949 and not duplicative in nature. Next slide, please. So for primary care loan forgiveness, we also, one slide back. We also recommend level funding. What we experienced in PCLF during the 1921 biennium was some high interest at the beginning and a dip in applications when COVID hit. I imagine, and we heard anecdotally that people were a little bit hesitant to sign service obligations without having sure footing in the future of the healthcare workforce, but we saw that dissipate during the last cycle when interest kicked back up. We feel like if we can keep level funding here, we're able to continue to make targeted awards to the right people that will create future healthcare professionals in Oregon. But the hope is that during this biennium, we'll have a little bit more competitive cycles so that we can assure those future clinicians commitment to urban underserved or rural populations and their understanding of providing care to historically marginalized populations. Next slide, please. So on slide 6, you'll see the program staff also recommending level funding for the rural insurance subsidy. We know several clinicians in rural communities are getting their malpractice coverage through group practice, but not all. For those who pay their own, this incentive is key to retaining providers in rural areas. During our listening sessions and being guided by the same guiding question, we heard about the value of this incentive. Many providers, specifically those doing OB/GYN services in rural Oregon, shared that they would look for work in different, or they would potentially or anecdotally look for different work or in a different area of the state if this incentive was not there to help them support the cost of their malpractice premiums. Furthermore, we see it as an opportunity to support hospitals that continue to deal with staffing shortages during the COVID pandemic. Next slide, please. So program staff are also recommending keeping level funding at $5 million for the 21-23 biennium for the Scholars for Healthy Oregon initiative being run at the Oregon Health Sciences University. The guiding question that we use for this and how we're really looking at showing moving forward is through the lens of how should we modify or enhance strategies to ensure recipient and community needs are met, and as well as looking at the redistribution of power and resources. OHSU is anticipating smaller class sizes, so it makes sense to look at the distribution of the funds to ensure consistency with the equity framework. And then we're also going to be having planned meetings with OHSU leadership to ensure that the equity framework is being applied to the awards that they're making, that the populations they're awarding are reflective of the populations that they serve, and that the direction being handed down from OHA, the Policy Board, and the Healthcare Workforce Committee is actually being executed, and that we're working towards the mission of eliminating health inequities. Next slide, please. So this next slide is for Showy Like, so the Scholars for Healthy Oregon Initiative like programs that are happening at different training programs throughout the state. We propose to add $1 million to the previous funding to result in $2 million of funding for this initiative. One thing the program staff is doing at ORH is working on an RFA, which will allow for applications from clinical training programs throughout the state to apply. This added money will allow us to add additional programs or for those programs that do participate to provide more awards and create more scholarships, resulting in future service obligations for a greater number of clinicians in Oregon. One thing that we heard during our listening sessions is that paying upfront for tuition for healthcare, particularly for non-licensed professionals, and working, if we really want to work towards diversifying the healthcare workforce and creating opportunities and career ladders for professionals, that Showy Like was a great opportunity to do that. By targeting the medical institutions and not having this be quite as wide open as would be ideal, we were really limiting the number of people who could participate, and by doing so, did not give the greatest opportunity for diverse populations to be awarded, or those with lived and life experience with the populations that we need them to be serving in the future. So hoping that we can increase the funding here, be a little bit more targeted about the awards, and support clinicians that are non-licensed, and really create those pathways for career ladders moving forward. Next slide, please. Okay, so this is the last slide of actual funding recommendations, and this is for a small increase of $300,000 for the administrative bucket for the program. What this does is it covers the cost of operationalizing the program. We've added new staff at ORH during the last biennium. And then moving forward, we understand that there will be the need for more targeted travel, targeted interaction, and making sure that we're reaching out to each and every community in Oregon, making sure that those who have historically slipped through the cracks, for lack of a better term, are being engaged. And we understand that there's going to be a cost incurred by doing that, increased travel and targeted outreach to those areas. So that is generally the recommendations for the proposals around the Healthcare Provider Incentive Fund. You can go to the next slide if you'd like. We're open for questions now, and any recommendations that you guys have looking forward, particularly as we aim to run the most equitable program possible and support the largest number of clinicians that we can.
Thank you, Joe. Comments or questions? Go ahead, John.
Yeah, terrific recommendations. This just made me think, though, of, I'm sure you all follow what the status is of, the billions, trillions in student loans from the federal government. And, another stunner this week was the 60 Minutes piece on just how impossible the feds have made it for lawyers coming out of the military to figure out, how to get their incentives to pay off their loans, things of that sort. And it just seems to me that there's a huge mess coming your way that will affect all of us. Because my understanding is the Biden administration has said definitely this year is it, where those loans are going to go back into action in 2022. So my guess is that will just have a huge effect.
Yeah, I can say from a program perspective, we're doing as much proactive thinking as we can to prepare for the administrative burden that I assume that will come from, I guess what will be a January 1 kind of flip of the switch for people's student loans being collected on again. So, we'll continue to be flexible, understanding, and patient as we work with the clinicians who are participating in our program and support them as they work through these changes. So yeah, I completely agree. I think we've got a large issue coming forward, and from the program perspective, we'll do the best we can to prepare and then deal with the issues that arise from it.
Other comments or questions?
I just make a reflection and with deep, deep appreciation for the courage it takes to actually live into the definition of redistributing power and resource. To the best of my knowledge, this is the first time I've seen it in quite this way, in quite a transparent process. And I really commend the committee in doing so. And so for the board's attention, that really is around the discussion of the Show We Like program. And using data and using all of that listening session detail to really emphasize the importance of thinking about the workforce and supporting it as we haven't done in the past. And I also just, Joe, as you said your presentation, I heard you say, and we recognize we didn't do it very well. And the honesty and the transparency of those conversations, I think, just strengthens my resolve in the power of this work and how this board can feel really proud of standing on the definition that we've created. So the OHA staff are leaning forward in that otherwise might be really rather uncomfortable conversations. So just wanted to.
It was truly amazing to see the progress over the last few years of where this was 3 years ago compared to where it is now. So yeah, very well done.
Chair Bangsberg, before we move forward with a vote on the recommendations, I do want to say much of what I heard right before I started presenting in the different communities, different settings that were expressed in terms of needing to be targeted are things that we've discussed as program staff, that we've discussed in the Healthcare Workforce Committee. And we continue from the perspective of the Healthcare Provider Incentive Program to figure out how within the context of the rules, ORSs, and kind of the different parameters that are set up that we can support those populations. And I am committed to continue to moving that ball forward so that we can, support a large number of clinicians that we know need a lot of help throughout the state that unfortunately aren't able to participate at this time. So thank you for that.
Any other concerns or comments or questions before we entertain a vote to approve the funding allocation? I'd like to entertain a motion to approve the funding allocation as presented.
So moved.
A second?
I'll second.
Second. Any discussion? Further discussion? All in favor? Aye.
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 Any opposed? Any abstain? Well, the funding framework passes unanimously. Thank you for a great presentation as progress. And also thank you, Brenda, for being a terrific liaison and advocating for this committee and shepherding this work. So well done, everyone. We next move on to the Healthcare Market Oversight Program to discuss a draft framework to review material change transactions. This will be presented by Jeremy Vandehey and Zachary Goldman, who will review the updated framework for the material change transactions for the Healthcare Market Oversight Program. You will recall that we heard from Jeremy and Zachary last month and provided feedback on this framework. They've updated this framework and here to share the updated framework with us today for proposed vote of approval. So Jeremy and Zachary, we'd like to take us forward.
Okay, thanks. I'm just going to turn it straight over to Zachary to dive in.
Thanks so much, Chair Bangsberg, and thank you, Jeremy. Hi, everyone. I'm Zachary Goldman. I'm the healthcare cost economist at the Oregon Health Authority. I work on Jeremy's team at Health Policy and Analytics Division. As Chair Bangsberg said, last meeting, we talked about the framework for reviewing proposed material change transactions. What I'd like to do for this meeting is talk about what the small edits that we have changed, and then lead right into a discussion. Next slide, please. Next slide. Okay, so during the September meeting last month, we heard some very specific, great comments that we've incorporated into the framework. The first was when the framework is talking about costs, we should be specific and we should mention cost to consumers and employers, and we've included that. We wanted to add the word commitment to the sustainable healthcare cost growth target, as opposed to achievement of. We want to do commitment and achievement of, so both are present there. In regards to access to care, we wanted to specify, or we heard that you wanted to specify equitable access to care, and so we've added that. Also, regarding the health of people, we heard that you wanted to specify improving the health of people, that a transaction should be, one of the goals of the transaction should be improving the health of people, not just considering it. The next is to add local public health authorities to the framework, and that's an important piece. We've added that. And then we heard the request to add back in a sentence from the framework on Senate Bill 1041 that was about CCOs, merger and acquisitions. And that sentence was about researchers' findings from consolidations. And we've done that. We've added that sentence back in. Let's go to the next slide, please. After the September meeting, we also heard via email some additional feedback, and I want to cover 2 points and then one additional point. This first was we should specify that researchers' findings from consolidation include cost increases. We didn't mention that previously, so we've added that. Oh, the slides are jumping around. Yeah, there we go. The second is to clarify the composition of the stakeholder review boards. And so we added a footnote into the framework mentioning what the statute says. And there's some key parameters around how many community members must be involved. There's a limitation on industry representatives can serve on that stakeholder review board. So we added that language because it's really important and aligns with much of what we talked about today, actually, including the voices that we're hearing and the folks that have some authority to weigh in. Not on here, but there's a third piece that we just heard late last night, so we didn't have time to add it to the slides. And that comment was to add local mental health authorities as well to the framework. And so we'll do that going forward. That's not in the current draft, but that's a very easy fix. We can do that. Let's go to the next slide, please. So here's where I want to open it up for discussion and approval. And after that discussion, I'd like to end with just a few next steps on what the program is pursuing. So you all have a good sense of what's to come in the coming months. I'll pass it back to you, Chair Bainsford.
Thank you very much. Okay. So before comments or questions from the board. Let me start off by just saying I really appreciate your responsiveness to the last comments, and also laying them out really clearly for us. Any other questions or comments? Kirsten, please.
I know the statute uses the term stakeholder, but I guess I was wondering, given recent conversations with them that I've been learned from OHA about kind of how that term can be problematic, I wonder if we want to swap out more a synonym or neutral term for stakeholder where possible there. But also really appreciate the thoughtful listening and incorporation.
Yes, we could do that.
John?
Yeah, I really support this and appreciate the chance to review it and make suggestions and the changes that were made. I did just want to comment on the written testimony. There was a comment about we want to make sure that this process uses established facts. I take that as a call for transparency. As having been through multiple mergers and acquisitions, establishing the facts, even for the two parties involved, can sometimes be quite the due diligence process. I hope that in this process, the public especially, because I think patients are the third party in these arrangements will have access to the established facts. Thanks.
Thank you, John. Bill?
Hi, I'd like to commend the Zachary and Jeremy and the staff there for putting this together. I think it's very solid. Appreciate the opportunity to offer comments, and I support all the changes that have been made. It's clarified and strengthened the document. I think it was also good that they recognized the input from the OHHS, that was and rewarded the these guidelines appropriately. I think that the assessment should be based on facts, and in that input letter that was introduced earlier in the in this meeting, there was reference to a specific study. That's one study, which I understand was commissioned by the American Hospital Association, but there are many other studies too, and I appreciate the staff looking at all the academic literature on this, and I think that the revised wording in this accurately reflects the literature on this issue. So nice work on responding to that and handling it appropriately.
Thank you, Bill. Other comments or questions? Thoughts before we move towards a vote?
No, nothing that hasn't already been made.
All right, great. All right. Then I'll entertain a motion to approve.
So moved.
Second?
Second.
Any further discussion? All in favor, say aye. Aye.
Aye.
Aye.
Any opposed? Any abstain? Well, thank you very much. The framework is approved, and I think you wanted to talk about next steps, Zachary.
Yes, please. And can we go to the last slide there? We wanted to share the website of the program. We included some good information there. So we're trying to socialize this as much as possible, sending emails out via Gov Delivery, connecting with groups, connecting with existing meetings, etc. So here's the program website. We also wanted to request input from community members, interested parties, whomever has thoughts about this new program. We have an email inbox set up, and so any and all thoughts are welcome. And then a call to action here. If anyone listening out there, if anyone knows an organization or an individual who would like to formally represent either themselves or their organization on the Rules Advisory Committee, those meetings will be held on October 25th and November 4th. These are the official regulations of the program. We are seeking RAC members, Rules Advisory Committee members. So please email that inbox right there and let us know if you'd like to participate. Other than that, we're excited to get this program off the ground, and I turn it back to you, Chair Banks.
Sorry, Zachary, did you say turn back to me or Chair Bingsburg?
Oh, Chair Banks, but Jeremy, I welcome it, of course, if you have any thoughts.
I'm going to tell you Jeremy changed it there. I have nothing to add.
All right.
Okay.
All right. Well, it looks like we're wrapped up on this agenda item. And we'll move to our grand finale for this meeting, the cost growth target implementation update, where Sarah Bartleman and Jeremy Van de Hey will join us to share updates from the program implementation, including recruitment and public hearing efforts. Sarah and Jeremy, will you take us forward? And one more note, I want to let everyone listening know that the Cost Growth Target Advisory Committee is recruiting new committee members. If you're interested in participating, please reach out to OHA.
Thanks, and I'm just going to turn it straight over to Sarah like I did Zachary. So Sarah, dive in.
Thanks, Jeremy. Thanks, Chair Bingsburg. We're just wanting to share a couple of status updates with everyone where we are with the Cost Growth Target program. and what's coming up in October and November. So as Chair Bangsberg just referenced, and as Susan Otter and Ignatius Bao shared in their agenda item, our new Cost Growth Target Advisory Committee recruitment is open. We opened that in mid-September. Applications are due October 15th. And we plan to bring back a proposed slate of membership for the board, for the policy board consideration at your November meeting. So again, this is our advisory committee that will replace the current implementation committee, which sunsets at the end of the year. We're hoping to have the new advisory committee appointed and ready to go by January. And as Susan and Ignatius shared, we're piloting some of the forms and processes from the committee membership work group for this recruitment. The recruitment notice and the forms are posted on our website. The link's on the slide here, and Tara has also shared the link in the chat earlier in the meeting today. We've broadly distributed it to a number of our distribution lists, interested parties, Gov Delivery, all of that good normal recruitment. We're also working on getting the word out more broadly to community partners, and we're hoping to do some more of that push this week and next week. And of course, we ask policy board members to help us share the word of this recruitment. So far, we have not received an overwhelming number of applications, so hoping to do a little bit more of a push this week and next. And we'll come back to you in November for this. Next. So on Friday last week, we reached one of our first big milestones for a cost growth target program implementation. Our initial data submission was due on Friday from the payers. This was the submission of calendar years 18, 19, and 20 data. So we're planning on using this to understand what's been happening in Oregon. This is not data that we're going to be using for direct comparison to the cost growth target. And for accountability purposes, this is just for building the program and making sure we have that solid foundation. So we've spent a lot of time this spring and summer with the data submission template, working with all of the payers on their data submission, figuring out all of those technical questions. And Friday was the due date. And we're really happy to report that we've received data from the majority of submitters. We granted extensions to a couple of payers who had more complex situations or had some other snags and needed a little bit more time to ensure accurate and complete data. And we really wanted to prioritize making sure that we get accurate and complete data. So it's worth taking a little extra time to get it right this first time. We also want to note that some payers had some unforeseen challenges. One payer reached out to us to say that they had lost their entire IT and data team over the summer, and all of their new staff had to come up to speed on our data submission template and requirements. So we wanted to be as flexible as possible, but I really just want to give kudos to all of the payers who have been participating and working with us. This was a big lift for them, and we really appreciate how much work they've put in, and we're excited to start digging into the data validation, which we already started. So that multi-stage validation will be happening. We had previously talked about this with you, and happy to share more information if anyone's curious about the details, but we'll do some initial quality checks on the data, and then we'll reach back out to each of the individual payers with specific questions to make sure that we're reading everything that they submitted correctly and that we work through any questions before we know that the data is good and ready to start analysis. We also, at the payer's request, this is something that came up in our technical advisory group meeting, we're going to be providing data submitters with a weekly report on the validation status. So hoping to be transparent about how we're moving through this process and how close we are to being ready to go. So we're happy to provide any more of this information back to the board at any point. It's pretty technical, in the weeds, maybe more in the weeds than you want, but again, just really happy that we met this milestone and we're moving into the next phase of the program. And finally, I wanted to share a little bit back with you about planning for the initial public hearing. So we had previously talked about this at, I think, the last couple of board meetings, and we agreed that a planning group with a couple of policy board members and cost growth target implementation committee members would get together and have a couple of conversations to put together a proposal, timeline, agenda, and some of the objectives for the initial public hearing. Next slide, please. So that group has met once and they will meet again in October and agreed that the goal would be to hold the initial cost growth target public hearing before the February 22 short legislative session. We're thinking maybe January. We haven't fully pinned down the date. We have some outstanding questions. We know holiday scheduling is really challenging. We know COVID is still challenging, but we think it's important to get this on the calendar and start this coordination before session, because this can inform can really provide some context for session. So more to come on the actual date, but next slide, we did make some progress on what the objectives for the initial public hearing would be. And these objectives will shape the agenda development, the topics, and the presenters that we would invite. So to summarize, the two objectives are to publicly launch the program and to continue to build awareness of Oregon's cost containment efforts, and to provide a venue for legislators, partners, and the general public to build that understanding of the pre-COVID healthcare cost trends in Oregon and the impact of healthcare costs on marginalized populations. So we know that COVID has really affected a lot of things, including cost trends. And we know that 2020 and 2021 will almost certainly be outlier years in looking at the cost growth data. But we really want to have that solid understanding of what was happening in Oregon before COVID so that we can understand what exactly COVID changed and have that all set us up for the foundation as we move into the annual program cycle. So we also want to build on these objectives to think about what are some of the successes and challenges currently in the system so that we can build towards those future efforts to meet the cost growth target. So next slide, please. We will meet again with a small group in October to continue developing the agenda. We'll start looking at some preliminary data to prioritize potential topics to bring forward onto the agenda, finalize the dates, and identify presenters. So we'll hopefully have more of a solid plan for the initial public hearing by the end of the month, and more to come on that. And policy board members, those of you who are part of the planning group, would any of you like to add any detail or context that I missed?
Go ahead, Bill. Yeah.
Nothing to add other than just to say that I'm pleased with the progress we're making on this. Sarah's done a great job of organizing this effort for the launch, and looking forward to working with her and the other folks to move this forward. It's a very important initiative.
Thanks, Bill. Okay, those were all of the updates that we had prepared for you today. I'm happy to take any questions about these or anything else related to the cost growth target program. Jeremy, anything you want to add?
Questions or comments?
Nope, nothing to add. I just, I think really looking for direction or feedback on kind of timing and making sure that we're in the right direction, but nothing else to add.
John?
Yeah, great to see this moving forward. For myself, I would love to see an interval report on who has gotten over all the hurdles in terms of submitting data and who hasn't, because I think that's a key indicator of how this is going to go. My own preference would be to see that somehow expressed in terms of number of lives. That's, I think, the important part. It would be great if we could be confident that the costs for 3.5 million of the 4 million Oregonians are going to be addressed. I can certainly see how some small insurers might not participate, and I don't think that's a problem. But if some of the larger insurers don't, and I think that would be a sign of some challenges ahead.
Thanks, John. I think we would be happy to report back to you at the November meeting with where we are with the data submission and validation. There were some, again, technical details from the implementation committee about where our threshold was for number of covered lives in Oregon to be a mandatory data submitter. So I think we can definitely report back on the number of covered lives as requested.
Any other comments from the board? Well, thank you, Sarah and Jeremy. Also like to thank all of OHA staff for preparing really detailed reports for us today, really thoughtful and incredibly responsive presentations that have grown and evolved over months and years of deliberation. And want to thank my fellow board members for providing the guidance to OHA to really stimulate this progress. It's really a pleasure and a source of pride to be part of this process. So thank you to everyone at OHSA, the fellow board members for this meeting. We are ending a bit early, which is a good thing, and I'll give you back 25 minutes of your day, and look forward to seeing you all on November 2nd for the next Oregon Health Policy Board meeting. And with that, I'll call this meeting adjourned. Thank you, everyone.